The FDA just approved Tonmya for fibromyalgia, though you might know it as cyclobenzaprine or Flexeril. What you may not know is that it carries 3 serious risks for your patients and your license. Welcome to the Carlat Psychiatry podcast, keeping psychiatry honest since 2003.
I'm Chris Aiken, the editor-in-chief of the Carlat Psychiatry Report.
And I'm Kellie Newsome, a psychiatric NP and a dedicated reader of every issue. There are 3 FDA-approved medications for fibromyalgia, and the FDA just added a 4th. All of them have psychiatric risks and benefits. And today, we'll cover a new one, cyclobenzaprine, which was just approved as a sublingual form, branded Tonmya. Like we covered in our recent ketamine podcast, this is a secondary approval. New form, new use, new brand name. In terms of symptoms, it's an important advance for patients, improving sleep and physical pain. But it carries 3 risks you need to know about. There are overdose deaths when combined with benzos or opioids, and the DEA is in hot pursuit of clinicians who prescribe those 3 together. It can cause mania and psychosis, and in the elderly, it may cause more trouble than it's worth.
First, let's review past fibromyalgia approvals. It started with pregabalin Lyrica in 2007. Pregabalin may lack FDA approvals in psychiatry, but it is useful there. It's actually approved in Europe for generalized anxiety disorder, and I think it should be recommended there here in the US as well. Pregabalin is more effective than SSRIs and SNRIs in anxiety disorders, judging by its effect size, and it has better evidence than its gabapentinoid cousin, gabapentin, in anxiety, especially in GAD and social anxiety disorder, where pregabalin is dosed at 300 to 600 milligrams a day, usually all at night. With its ability to deepen sleep quality, pregabalin is preferred in fibromyalgia for patients with sleep problems and pain.
Next came 2 SNRI antidepressants, duloxetine, Cymbalta, in 2008, and milnacipran, Savella, in 2009. In psychiatry, duloxetine is approved for depression and generalized anxiety disorder, and that anxiety indication stretches all the way down to age 7. Outside the US, duloxetine is also approved for urine incontinence, and that reveals a pearl you need to know about this drug. It can make it more difficult to pee, which is a good thing if you have incontinence, as many older adults do. But if you don't, that can lead to urine retention and UTIs. Off-label, duloxetine improves binge eating and prevents migraines, and is one of the antidepressants with the most cognitive benefits, along with vortioxetine and bupropion. Milnacipran has no psychiatric approvals in the US, but it does treat depression. It's approved for that in France and Japan, and its isomer, levomilnacipran, is FDA approved as Fetzima in major depression.
If you've not used levomilnacipran Fetzima for depression, you're not alone. Its late entry into the field in 2013 and its branded status have slowed its adoption. But consider levomilnacipran as a second line after bupropion for patients who are lethargic and slowed down, the types that you'd use bupropion for. Like bupropion, levomilnacipran is a slightly activating drug. It's the most noradrenergic of the SNRIs in the US. So there was a rush of new approvals in fibromyalgia 15 years ago, all 3 of them in a 2 or 3 year period. And here's how things stand with those 3 FDA-approved agents now. In fibromyalgia, pregabalin is preferred for patients with sleep problems, while the SNRIs are preferred for those with fatigue, depression, and anxiety. When patients have sleep problems and depression or anxiety, doctors often use low doses of amitriptyline off-label. And amitriptyline has a very similar structure to this new one, cyclobenzaprine. Next, we'll look at where cyclobenzaprine fits and the psychiatric risks that it brings.
After 2009, we saw no new approvals for fibromyalgia until August the 15th, 2025, when the FDA approved cyclobenzaprine. But cyclobenzaprine is not new at all. It was approved as a muscle relaxant, Flexeril, in 1977, the same year that fibromyalgia entered the medical lexicon. The first controlled trial of cyclobenzaprine in fibromyalgia came out in 1989, a year before the American College of Rheumatology released the first criteria for the disorder. As the 1990s progressed, cyclobenzaprine grew in popularity, and it remained one of the most commonly prescribed medications for fibromyalgia, even as the other three gained FDA approval.
In 2016, researchers looked at prescription patterns for 250,000 privately insured patients in the U.S. with fibromyalgia. Even though it was off-label, cyclobenzaprine was the most commonly prescribed medication for fibromyalgia. 1 in 3 people with fibromyalgia took it, a rate that was 2 to 4 times higher than for the approved options. And that might be because the approved options were all brand-only back then. But the second most commonly prescribed treatment was an opioid, also off-label, an opioid with SNRI-like properties, tramadol. Tramadol is not approved in fibromyalgia, but it's used off-label there, and it is recommended by the American College of Rheumatology.
That combination of an opioid, tramadol, with a muscle relaxant, cyclobenzaprine, highlights the first psychiatric risk with this new approval. Because when you add a benzodiazepine to that combo, you get what the DEA calls the Holy Trinity, an abusable combination of sedatives that seriously raises the risk of respiratory depression and death. That risk is not as bad with cyclobenzaprine. The riskiest muscle relaxant is cariprazine, otherwise known as soma, because cariprazine is metabolized into a barbiturate. So in that case, it's no longer a trinity, it's a quaternity. An opioid, a muscle relaxant, a barbiturate, and a benzo.
So check for cariprazine, soma, and opioids on the med list before prescribing a benzodiazepine. And watch out for cyclobenzaprine as well. Cyclobenzaprine also raises the risk of respiratory suppression when combined with opioids, alcohol, or benzodiazepines. Actually, pregabalin, gabapentin, antipsychotics, and psychostimulants also raise that overdose risk, though not as much as the muscle relaxants, and with the exception of the psychostimulants, they're not as much on the DEA's radar. The U.S. government has prosecuted doctors for prescribing an opioid-benzo combo along with other muscle relaxants like baclofen. On the juicy DEA web pages that detail these prosecutions, some of them define the Holy Trinity as an opioid, a benzo, and cariprazine, restricting it to the riskiest of them, while others use the more generic term muscle relaxant, broadening their radar. You know, it's tempting to criticize the government here for this lack of precision, but if we're going to go down that road, maybe we ought to call them out for keeping all of this hidden. I mean, if this is such a danger to the public, and I do believe it is, why haven't they put out a Dear Doctor or Dear NP letter? If any of our listeners got one of those from the DEA about the Holy Trinity, please send it to me at Aiken@thecarlatreport.com. These prosecutions took a harsher turn a few years ago when the DEA started prosecuting pharmacies just for filling the Holy Trinity, including the entire Walgreens chain. While they don't warn clinicians about the problem, they have told pharmacists to watch out for it, and they have warned pharmacists that if they fill too many of these scripts, instead of turning the clinicians in, the government will prosecute the pharmacy. So bottom line, next time you get a call from a pharmacist questioning your prescription of clonazepam, be respectful. You could save your license, and you might just save a life.
We counted nearly a dozen prosecutions of clinicians for the Holy Trinity, with some serving jail time and some paying million-dollar fines. The DEA is mainly interested in pill mills, clinicians who supply these meds on an industrial scale without a medical indication. But justice is imperfect, and any one of us could get caught in that grind, especially when the DEA has already written that there is, quote, no acceptable medical justification for prescribing these three together.
That might sound a little presumptuous on the part of the DEA, considering 2 points of the Trinity are the most commonly prescribed medications in combo for fibromyalgia, with endorsements and practice guidelines and now partly endorsed by the FDA. And the other point in the Trinity, the benzo, is FDA approved for anxiety, which affects 50% of patients with fibromyalgia. So where do we get off saying there's no medical justification here? And this might explain why the Trinity is so common, despite the DEA's unreferenced pronouncement. Here are some stats from an Express Scripts study. Of everyone in their database prescribed an opioid, 33% were also taking a benzo, 20% were also taking a muscle relaxant, and 8% were taking the Holy Trinity, all three. That study was done 10 years ago, and in fairness, we do have reason to think that the numbers have declined a bit since then.
The bottom line, watch out. Lives are at risk here, and regulators are on alert for a poorly defined combo called the Holy Trinity. Lots of patients are coming in on it. No one has issued guidelines on how to stop it or when it's okay to use it. And the FDA just gave a green light that is likely to expand it. Let's pause for a preview of the CME quiz for this episode. Earn CME for each episode through the link in the show notes. Which population is at greatest risk for anticholinergic side effects on cyclobenzaprine? A. Obesity. B. Bipolar disorder. C. Patients on opioids. D. Elderly.
Our next cyclobenzaprine warning concerns the patients who were conveniently left out of the FDA registration trials, those with psychiatric disorders, those over the age of 65, and those with complex med regimens and complex comorbidities were all excluded. Like a lot of treatments for fibromyalgia, cyclobenzaprine acts as a serotonin and norepinephrine reuptake inhibitor, or SNRI. It also has anticholinergic effects and blocks histamine and muscarinic receptors, adding to its sedative and muscle relaxant properties. But what concerns us first is that it is an SNRI. Chemically, it bears a close resemblance to amitriptyline. For many patients with fibromyalgia, that's a good thing. In animal models, cyclobenzaprine treated depression. But for patients with bipolar disorder, this is not a good thing. There are case reports of cyclobenzaprine triggering mania and psychosis that resolved after the medication was stopped. 1 in 5 patients with fibromyalgia have bipolar disorder, so this is something to look out for.
The bottom line, if your patient with bipolar disorder has manic symptoms, mixed states, or rapid cycling, check if they are also taking cyclobenzaprine.
Our third risk concerns anticholinergic effects. This is going to fall harder on the elderly, the ones who were left out of the registration trials, as well as those with chronic medical disorders. Anticholinergic side effects add up as the medication regimen gets longer, and eventually they reach a tipping point for all of us. The threshold of danger is just lower in the elderly. Here's how you know that you've gone too far with the anticholinergic burden.
Constipation. In the worst case, bowel obstruction with potentially fatal paralytic ileus and sepsis. Your patient is having trouble reading from dilated pupils and impaired papillary accommodation. Your patient complains of bad breath, or their dentist discovers more gingivitis, both from the dry mouth that anticholinergics cause. Or maybe they have more UTIs, a downstream effect of urine retention. They have more asthma, bronchitis, and respiratory infections from the mucus plugging as the airways dry. In the registration trials for cyclobenzaprine, patients on the drug had more COVID infections than those on placebo. In the summer, they overheat.
And finally, they get more delirium and cognitive impairment, something long known with cyclobenzaprine, and one of the reasons we want to avoid this drug in dementia. I check anticholinergics routinely with older patients, as many of our psych meds add to that burden. A good resource to accomplish that is the Anticholinergic Burden Scale at acbcalc.com. That's CALC, calc.
Those are the three big risks: overdose with sedatives and the Holy Trinity, rare mania and psychosis, and anticholinergic effects in the elderly. Cyclobenzaprine also causes drowsiness, dizziness, and falls. And we would be remiss not to point out a critical drug interaction. As an SNRI, it can cause serotonin syndrome and is contraindicated with MAOI antidepressants. But we do hate to be such a Debbie Downer, so let's end this podcast with evidence-based things our patients can do to improve fibromyalgia before they start adding on medications. Most are lifestyle changes we use for depression. Light exercise, both aerobic and strength training. Yoga, Tai Chi, Pilates, and acupuncture. Mindfulness. Cognitive behavioral therapy, especially CBT for insomnia. And weight reduction. Join the conversation and get daily research updates from Dr. Aiken's daily psych feed. Search for Chris Aiken MD on LinkedIn, Twitter, Facebook, Blue Sky, and we are back up on that quaintest of social media sites, Threads. We'll be back next week with our series on how to start a psych med.